gentleman over here made this. AGS guru, you are.
Yeah, AGS.
In this section, we're going to go through each of the 25 items on the exit so you can see sort of what they're about, where they came from, what the rationale for them is. The exit is kind of a funny measure in a lot of respects. It's really not like, I would say, most paper and pencil testing. And that's why, part of why I named it an interview. It's more like a clinical interview, eliciting signs of frontal lobe brain disease. Or nowadays we would recognize that it's frontal circuit brain disease because you really can't localize these signs to the frontal cortex exactly. And most of them are adapted from the literature that I could find, now almost 20 years ago, equating focal frontal cortical lesions with changes in behavior. But they had the added requirement that they had to be things that were not educationally or culturally or linguistically demanding, because I wanted to avoid the sorts of traps that many traditional measures had fallen into over the years. And I also wanted items that the examiner could do at the bedside, even though they weren't necessarily very knowledgeable or experienced. It had to be very simple things. And then I wanted them to be done with no equipment or paraphernalia. So this constrained the set of possible items to just 50 that I just sort of carried around in my head for a while and just threw into my mental state exams. But I kept finding so many people who failed that I realized pretty soon that this was much, much bigger than just dementia as traditionally defined. And then we honed it down psychometrically to these 25 items. Okay. And as I go through this, we have these embedded video clips. These go to intact performance, and the red ones go to impaired performance. And you see that the way I did this was we took a real volunteer, he's not a patient, but he's moderately intact. And basically, we filmed him doing the exit, and everything that he did wrong, and we kept that spontaneously, but then we coached him on how to do it right. So it's the same guy, the same examiner. One path leads to failing, the other path leads towards passing. And what's interesting about this is how, well, he's not an actor playing executive here, right? Because one of the things I hate about watching people's videos on tests is that you can tell that these actors aren't really doing what real patients do. But this guy's failures are relatively convincing. Okay, so the first one is basically a verbal adaptation of the trail making test, right? So alternating sequences. And the way I see this as working is, like I said, behavior is built from overlearned pieces. And these are things that, if you've done a million times, you can't help but learn them as habitual overlearned behaviors. But they're very stereotyped, and they're driven by cues. So that when the cue is present, the behavior suggests itself to your mind, and your executive function doesn't have to do any work. It doesn't have to choose them or find them or select them, so that most of these things just occur to you spontaneously as you go around life. And your only decision is whether to stop them. Otherwise, they will be executed in behavior, right? And some cues have associations with multiple overlearned behaviors, and they all simultaneously may present themselves. Some of them are stronger than others, but sometimes the weaker one is the right one to solve your problem. And so what the executive function has to do is inhibit the overlearned behaviors that are irrelevant to your goal, even though they may be stronger and fighting more forcibly to express themselves in behavior. When it comes to something like this, you have two overlearned behaviors that are fighting each other. One of them is number, and like I said, counting. And counting goes from 1 to 10, right? It stops really at 10. And the other one is the alphabet. And so basically, you have to open up one of the behaviors, take one step, shut that one down, shift to the other behavior, open it up, take one step, shut it down. What I'm trying to describe here is what an engineer or a computer scientist would recognize as a cybernetic control process. And I think that basically my conceptualization of executive function is as a set of cybernetic control tools. That's why I talk about it as executive control, not executive functions or executive cognition. This may be only a subset of what the frontal lobes do. The frontal lobes surely do other things that aren't necessarily cybernetic. But I think it's the cybernetic functions that are most relevant to functional outcomes and are most responsible for the problem behaviors that we see in the setting of dementia and executive impairment. There may be other frontal functions. You think of abstraction, for example, proper. So like in mental state exam, it's common that neurologists or the clinicians are taught to ask these propers and see how the patient responds. But I was never impressed with those as a clinician, and that dimension of frontal lobe function doesn't predict functional status. So that's not what I'm talking about. There's not one item on the exit that asks for an abstraction. There is no planning. There is no judgment involved in the exit. It's decision-making as operationalized as a set of abstract cognitive skills is not what I'm talking about. Right? And it may be that those abstractions are related to frontal lesions, particularly dorsolateral lesions, but those lesions aren't necessarily all that the frontal lobes do, or even the subset of things that are related to functional outcomes. So I think part of what made the exit really click is that it didn't really go after any of those things, and it went after these control processes instead. Now, this is just in retrospect. I don't have any proof of that, but that's just what I think is going on here. Because the exit is singularly good about predicting functional status in a way that most other measures, even putative executive measures, can't duplicate. And I think it's because fundamentally they're looking at different dimensions of executive control. Another thing that the exit does is it's choreographed. The order of the items and what it tells you to say and do is choreographed to improve the ability of the examiner to notice what the patient is doing, what's wrong, by basically constraining their possibilities. And I guess it sounds weird, but what I mean is, one of the items, for example, was Francois Lermit's clap. Okay, so Francois Lermit was a French neurologist who noticed that if he spontaneously clapped his hand in the middle of an interview, 60% of psychiatric inpatients will imitate a clap, but 0 of 300 medical students that he did it to. Right? And he thinks of this as imitation behavior, and he equates it to orbitofrontal structural brain disease. So basically that was easy. You could do it at the bedside. It didn't require any education or culture, so it became something in the case. Okay? Well, you're never going to get a little old lady with a purse in her lap to put down her purse and imitate your clap. This is not going to happen. So to test that item, the patient's hands had to already be up in the air. So that item follows the one where the woman is putting her fingers like this, because the item, the test itself is choreographing the movements of the patient and the examiner to make it more likely that some of these things will happen, and more possible that they'll happen, because otherwise you would just never see these things. You see? So I'm improving inter-rater reliability and test-retest reliability by forcing the examiner to do things in a particular sequence. And so it's really a lot more than a paper and pencil test. It's more like a choreographed interview, and that's emphasized in its title. So the first one here is this oral trail making. And just like most exit items, they're scored 0, 1, or 2. And then you can say, okay, now you try it. Start with the number 1, keep going until I say stop. Okay, and it's unambiguously scored. There are no errors. They completed, but they messed up the first time, and you got to repeat the instruction once. Okay, and if they fail the second attempt, then they don't complete the test. So the exit is telling you when you can prompt, how you can prompt, and other than these particular opportunities, you as the examiner cannot tell the patient what to do, help them out, explain things to them. Basically, all of the responsibility for these responses is placed on the patient so that you can see what they're capable of doing. And so now let's just look at the video here. Oops, there was that.
I do it this way: 1A, 2B, 3C. Start back at 1. Try it again.
1A, 2B, 3C. 6C, 4D, 5E.
Stop.
So in that case, you would have gotten a 1 because it failed the first time. She gave him a second chance. Okay, the second one is a verbal fluency item. Now, there are a whole lot of verbal fluency tests out there. In most languages, certain letters have been chosen empirically by big studies to see which works best. People are generally looking for letters that lead to not too exhaustive a list of words, but also not too short. And the letters also have to lead to words that are, not very difficult, or require a lot of education to know the word that starts with the letter X. So in general, there's a common test that uses in English the letters F, A, and S, and there's another one that uses C, F, and L. Okay. Other languages may have other letters. So in some of the exit translations, they're not using the letter A, they're using whatever letter works in that language. Another thing is I don't really want the examiner to get all hung up about whether that's an adverb, a noun, an adjective, a name. It makes the grading too complicated. So basically, the way this works is any sentence that starts with the letter A, any word that starts with the letter A is fair game. Right? And it doesn't seem to matter. So I'm going to give you a letter. You have 1 minute. Name as many words as you can think of that start with that letter. For example, letter P. You can say people, pot, plant, potato, so on. Are you ready? Go. If they get 10 or more words, then they get full credit. If they get between 5 and 9, they get partial credit for 1. If it's less than 5, then they fail. I don't think this guy is going to fail that out. But you'd be surprised. People generally get like 2 and then shut down. Just go shoot. And they have a full minute. And you can't mark them. You're just watching them. And they may lose complete train of thought and just look up and they're not playing anymore. It's not up to you to keep them focused on the task. That's the executive impairment, is they're not playing the game. Okay, design fluency. Now, here I get a lot of questions about this. There's a blank page, a big space, and then the instruction about that. Okay, and the instruction is look at these pictures, but we don't provide any pictures, right? That's because we want you to model the drawing of the pictures while you give the instruction. So you're going to make out the pictures. I don't care what the pictures are, as long as they respect the rules of the game. And in general, what I draw are a bunch of stick figures, and you'll see that again. So I'm drawing these little stick figures, and while I'm drawing, I'm saying to the guy, look at these pictures here. Each one is made with only 4 lines. And then I stop for a second and draw them. 1, 2, 3, 4. I'm going to give you a minute to draw as many different designs like these as you can. There's only 2 rules. First of all, no 2 alike. You can't copy any of mine. Every one you make has to be different. And the second one is that each statement drawing has to be drawn with just 4 lines. Okay? I don't care what the lines are, their orientation. I don't care if they're wavy lines or straight lines. What people tend to do is they imitate visual cues around them. So most people, even people with normal executive function, will be biased, prejudiced by the drawings that you drew. And since you're drawing stick figures, they tend to limit themselves, even without your complicity, to drawing stick figures. And that's counting against them. A really competent person, a young adult, a medical student, somebody who's thinking outside the box, realizes soon that they don't have to stick to stick figures. You can draw wavy lines, pretty lines, anything you want, as long as they're 4 lines. And so that kind of creativity we don't see very much. Instead, what you'll generally tend to see are stick figures just like yours. But it's interesting to notice that because you can really see some people shine by thinking through the edges of the problem and coming up with novel solutions to it. That's really a good sign. Let's see
Each is made with only 4 lines. I'm going to to give you 1 minute to draw as many different designs as you can. The only rules are that they each must be different. You can't copy mine. No two can be alike, and each has to be drawn with 4 lines. Go ahead.
This happens a lot. He's imitating her drawings, even though she just told him not to do that. You're not supposed to correct him, you're not supposed to help him out. He's not going to get credit for any of those drawings, no matter how many he did. Now, another thing is that I put these 2 items back to back, verbal and design fluency, right up front in the exit. Verbal fluency has the strongest item correlation with the total score. So you can get a sense right up front of how good they're going to do on the whole test. And design fluency generally should match verbal fluency. Whatever they score on one item, they should do the same on the next one. Because executive functions are metamodal, and these fluency tests operate across domains. So it really doesn't matter what's being controlled. It's a kind of control function to do a fluency test really fitting that. And so basically these are asymmetrical. Let's say you totally bombed out on verbal fluency but did great on design fluency. That might indicate that there's a focal disease process in one hemisphere or the other, and give you a warning of that right up front as you go through the rest of the test. You see, so our intention in putting these back to back right up front is to alert you to the possibility that the results will be contaminated by focal region outside the frontal lobe, and for you to convince yourself that executive functions are multimodal. It really doesn't matter what's being controlled. See, I think one of the mistakes people make is they concentrate on the content of tests and overlook the form. Right? And just because something purports to be a design fluency test doesn't mean it's a different kind of test than a verbal fluency test. And that's, I think, why Clocks 1 can predict things like financial decision making, even though there's not a single content of Clocks 1 that has anything to do with decision making or finances. You see, because executive functions are metamodal and operating across all aspects of behavior.
Look at these pictures.
Okay, next one. You heard the guy in the video fail this. Is a bunch of overlearned verbal, let's call them habits. I don't know what you call them, verbal phrases. These are so common that everybody knows them. But they're also culturally bound. Everybody in the United States knows them. Again, in other countries, you have to come up with your own stuff. It wouldn't be these at all. But they have to be overlearned, very, very familiar. And what we did was change 2 aspects of it. One is obvious. We changed one of the words to something that semantically still made sense, but just doesn't go there. But the more subtle change that we made was we cut it off short. What you learn is not Mary had a little lamb. What you learn is that Mary had a little lamb whose fleece was white as snow, and everywhere that Mary went, the lamb was sure to go. That's the habit. And so what this is doing is tempting that habit to fire and demonstrate to you that the guy doesn't have enough executive control to stop it. Because habits are stupid, and once they start, they go all the way to the end, and then they stop. The guy who's counting, they stop at 10, because that's where the counting stops, right? And the same thing with these. So the guy in the video said, "I pledge allegiance to the flags of the United States of America," and some of them, go even further. And to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. Right? And not only that, but it isn't just the language. The habit involves the motor movement. The hand over the heart, and they'll go the whole way, the whole 9 yards. And you say, "Yes, sir, that's fine, but I just want you to say this: I pledge allegiance to those flags." And he goes, "Whoa, I pledge allegiance to those flags of the United States of America, to the republic which it stands." Right? Because he can't stop it. And I think a lot of problem behavior in dementia is predicated on this type of overlearned behavior being elicited by irrelevant cues. My problem is, I don't know what your life story is. So I don't know which habits you have. So we had to throw out a net that would capture as many people as possible. So So there's 5 of them here, and they're each designed, when we put in here, for different target audiences in our clinic. And you only have to fail 1 to fail the whole test. So you could pass 4 out of 5. If you fail 1 by running with it, it's over. You failed that item. Because basically it just means we found a habit that you personally have. So the Pledge of Allegiance was because we're affiliated with the VA, and so a lot of our patients are veterans. But the little ladies fail Mary Had the Lamb, and baby boomers fail the alphabet. Because in the United States, really, you weren't taught the alphabet in a sing-song kind of A, B, C, D, E, F, until after World War II. So earlier cohorts don't fail that way. It's the baby boomers who fail that way. You see? And so basically you got to think about this when you alter this item, because you have to spread a net broad enough that you're going to capture some of the people in the population that you're most likely to see. And we will look at that one again because you saw it earlier. Okay, now, tell me what's happening in this picture. It's a relatively vague picture without very much detail, and to pass, you have to name each of the characters, so the cat, the bird, and the kid, and then you have to say something about their interactions, their relationships, and then you have to say something, anything about the setting.
Tell me what's happening in this picture.
Oh my goodness, that poor little bird is a cat that's going after a little bird there, and it looks like the cat might be gaining on the little bird.
Anything else?
You let that
Well, this looks like there's a fellow, a child trying to protect the bird by taking the cat off of the limb of the tree.
there, you got Lynn. So by adding Lynn, he gets a 1. If he hadn't said Lynn, if all he had said was there's this kid trying to get it down, then he would have failed. Yeah, then you have to say the 3 actors. You have to name the bird, the cat, and the kid. I don't care if he's, sometimes they see it as a boy, sometimes it's a girl, it's a good thing. Right, then you have to have the relationships. So the cat's trying to get the bird, and the girl's trying to get the cat. Right? And then you have to name something about the setting. Right? So the bird's in a tree, or it's on a limb, or there's snow outside. Right? And in our experience, the most common thing that they ignore is the setting. They'll look at all the characters and the interactions, but ignore the setting. But remember, the medical student, you just, first thing, just nail it. There's a cat up in a tree trying to get that bird, and a little boy on the ground. What does the bird say? Okay. Now, one of the things that I intended to do with the exit is demonstrate to people what's wrong with the mini-mental. Now, that there are opportunities to measure executive function in the mini-mental if only they've been recognized, or if when you did the mini-mental, you knew what it was that you were seeing. And in my experience, one of the things that I see a lot on the mini-mental was intrusions into the memory recall from the distraction word which on the mini-mental is world. It's spelled world backwards. Right? And so what you get is apple table world. Right? And people go, nope, you've missed one of the 3 memory items. His recall is poor. But that's not recall, that's executive function. There was a verbal intrusion from the irrelevant distraction in the item above. You see, that's not really a recall error. That's an executive error. So there's a chance that you could have scored it as an executive error and quit thinking of that as a memory problem. You see? And so I wanted to emphasize that. So here's an item similar to the mini-mental's form, but notice that you're not grading memory. I don't really care if you get the items, all the items right, as long as you don't say cat. Right? So saying cat is what makes you fail, just like the Alzheimer's patient. Okay, and this is an interesting item. This is taken from the Stroop, right? The Stroop test. And in the Stroop test, first, there's a page with a bunch of colors. They're words, but they're the names of the colors printed, at first in black ink. And you time how long it takes the subject to read this words. And the words might be red, green, blue, blue, green, green, red, blue, green, blue, red, red, blue, blue, green, right? And they have to read that every time. Then you do it again, but this time the color, the ink, is the same as the word being named. And you do it again and time that. There's really not that much difference in the time it takes to do that. But the third time, the color of the ink is different than the semantic content of the word being read. And suddenly, people's performance just goes because of this, this interference between semantic content and what you actually see. So we did that again, but we didn't want to reproduce the exit colors, so we just chose the word brown. And basically, what color are these letters? And the guy says black, or he says brown. If he says brown, then you can prompt him here. Are you sure? It draws attention to the fact that something's wrong. And then he either gets it right or he doesn't. Okay, so the scoring is unambiguous. But we had problems with this item. For instance, a fraction of our patients come and they say green. And then the resident comes to me and says, Dr. Royall, who scored green? You know, it's not on there. Who scored green? But anybody have any ideas? They're all veterans. I've never seen this outside of the VA. Furthermore, I've never seen this outside of a male veteran. Only male veterans say green. Because they're colorblind. You're brown, green, colorblind. And their life story associates semantically the word brown and green with a stronger combination than brown and black. And so they uniquely say green for this item. And there's no way to score it. If you can't score it, you know, things like that happen. You can't create a test that's perfectly seamless. So if you encounter something that you just can't score, then I suggest that you skip it and go to the next one. And effectively, they get full credit for that item because you're not going to, your high scores are bad, you're not going to get many points for that, right? If you have to skip more than 2, then I would suspect the entire score as being invalid. But if you skip 2 of them or less, then I would accept the total score just without those items being put into it. Anyway, and you know, this can happen for, say, visual handicap, profound visual handicap can interfere with several of these items. But still, you know, I'm hard. I want to argue that blind people go to college, and even blind people can pass CLOCS 1. I've demonstrated that to my residents a lot. I can pass CLOCS 1 with my eyes closed, totally out of the field of it, by using other faculties to accomplish a goal-directed behavior despite my handicap, right? That's what happens when you have good executive function. You can do what needs to be done about your physical handicaps. And so I think, you know, nobody goes to assisted living because they have arthritis. It's impossible. You could be an amputee and go through rehab, learn to use prosthetic device, and go skiing next year. So why should an amputee, if that's an amputee, why should arthritis put you in a nursing home? Cognitive impairment puts you in a nursing home because you're failing to do what needs to be done about your physical handicaps. See? So it's really the executive function of putting these people at higher levels of care. Of course, that's what our multivariate models are showing.
What color are the letters?
It looks like black.
Now, the next few items are related to neurological soft signs. Okay, so this one here is looking for paratonia. And what you do is you grab the elbow and the wrist like you were going to check for cogwheeling, which is, you know, again, that's something that a clinician might do, but a psychologist maybe has never had to do that before. So this would be aspects of the exit that it actually takes a little fiddly with to get used to. So you're going to rotate passively the arm at the elbow, and I'll show you in a minute. And basically, as a clinician, what you can feel is some people are passive and other people aren't. And when they're not, it's not really due to neurological disease. I mean, I can demonstrate to you this is not a reflex. And so neurology has labeled this as paratonia, basically. And so what I see happening, what I think is really happening here, is behavior is now under my control. I'm the strongest cue in his environment, and I am demonstrating the behavior with my hand here. This is the behavior. And he is now imitating it out of imitation. So I feel that active resistance, and you just have to look for that. You have to get used to that. So let's see. And, you know, you're either sure, you're not sure, or it's not there. I'm going to put 2 or 3 of these together. Now that you got your arms up, then you're going to flip the palms over and ask the guy to just relax while you push down. And if the peritonia is present, he'll resist that by pushing back just as strongly as you push down. As a clinician, we often have trouble, actually, think about it, doing physical exams, getting the patient to relax. There are lots of things where you have to manipulate the patient and you need them to relax, and they won't. And you have to say, no, just relax, just stop it, relax. And then you go on to the next part of your physical exam, never noticing, what was that? Why is that there? What is the consequences of that? What's the meaning of that? And so these things can fly under the radar. Clinicians, they're right there in front of them. These soft signs of, they're called front signs. But the clinicians don't pick up on them, don't document them, and never notice that they're there. Because you've just been socialized to ignore that, get on and skip through the rest of the exam, and do reflexes. And so you're passing over opportunities to notice these very common soft signs of behavior. Okay. And then, as long as you got your hands down, you bring it back up, turn them over, and then try to elicit a grasp reflex, which is another frontal release sign. And here, you just pull your hand along the palm of the other patient and see if they lock into you with a grip. And you'd be surprised how strong this can be. Sometimes you can pull people up out of their chairs by this. And the exit offers you a chance to document what happens.
Okay, relax while I try to check your reflexes.
You can tell she's not a clinician. It's hardly ever.
Okay, put your hands like this. Just relax.
That is very common. That happens a lot.
Okay.
And then she's going to do that one, and he grabs her. And that's
Okay. Thank you.
But that first bit was a little bit of acting. Okay, this is another funny item. This one, you come out of all this sort of physical manipulation, and then his hands go down, your hands go down, and he may not even be noticing you for the first second, but you look into their eyes, and you have to wait till you get their attention. They notice that you're looking, and wait just long enough that you subjectively feel uncomfortable. Right? And then you say, thank you. Now, if the habit fires, they'll just say, you're welcome. You know, thank you elicits you're welcome. So they'll just say, you're welcome. But the fact that you felt uncomfortable probably means they should feel uncomfortable, which means, what just happened here? That's a weird thing. And so an executively competent person will ask a question to clarify, and I don't care what question they ask. They might say, is it over? Or, you know, are we finished now? And they'll ask any question to clarify what happened because they subjectively felt that that was awkward. But if that's not there, then the habit fires and they just go, thank you, you're welcome, problem solved, on the next thing. It never even occurs to them that something happened there. See? So, that one is uncomfortable. Some people don't like to do it, but actually, psychometrically, it improves the sensitivity of the test. And at least one study helped them predict the capacity to give informed consent by basically every item on the exit incrementally improved its capacity to predict a blind forensic psychiatrist's opinion of whether the patient had the capacity to give informed consent. There was not one item you could cut without sacrificing the accuracy of the assessment. And so basically this item adds incremental variance. It doesn't go beyond the other 24. Okay, here's another one straight out of the physical exam to, again, socialize primary care doctors into recognizing signs of executive impairment that they didn't even know were there right in front of their face. So when you examine the guy's tonsils, you know, you say, open your mouth and say, ah. And what you expect him to do is stick out his tongue and go, ah. But the sound that you actually make when you make this request is short. You say, open your mouth and say, ah. And what happens is executively impaired people don't abstract from what you just said to the generalities that they expect you and want them to do. They just give it right back to you and they go, ah. And you say, no, keep going. And they'll go, oh, ah. And then you have to model it, no, like this, ah. And if you ask any primary care doctor, who do you have to model saying ah to before they do it right? It's children and old people. In other words, two executively impaired groups. So basically, when you do this, you should pick up on these little bitty things. One of the things that really impressed me about Dr. Lakota's work was that he's anecdotally started telling me how the nurses in his clinic are picking up executive impairment from teeny tiny little behavioral things that happen when they get their blood pressure or when they ask them for their medications, things that the clinicians have been blind to before, but now the nurses are even starting to recognize all these things and say, oh, you need to check his exit today, this, this, and they can tell that from just the tiny little variations in how they respond to these sorts of routine caregiving requests. That's pretty straightforward. The next one is another frontal release sign called a snout. You put your index finger across the lips of the patient and just tap it lightly like that. And they're supposed to pucker. Okay, that would be a positive snout. Sometimes it's equivocal, right? You're not really sure if that was a snout or not. So then you score it as equivocal. It's either you're sure it's there, you're sure it's not there, or you're not really sure. Right? So I wouldn't get hung up about whether they truly had a snout or not. I wouldn't hit them 10 times and have one of them work and none of them not work. I'd just do it once and just interesting. And that would be really bad. You wouldn't see that very often except in frontotemporal images. Okay, finger, nose, finger. This is just something that I noticed anecdotally doing routine neurological exams. I would say, touch my finger, now touch your nose, right? And when I hold my hand up, it becomes a visual cue. And visual cues attract behavior in executively impaired people. And they like to imitate too. So I say, touch my finger in step 1, and he puts his finger on top of mine. But now it's trapped. It's a prisoner with my finger because my finger is a visual cue and it won't go away. And then I say, now touch your nose. But I leave my finger up. And because his finger is glued to me, his only option is to use the other finger. He can't disengage from my finger. And so this is amazing. And yet patients do this all the time.
Touch my finger. Now touch your nose.
See, that happens every day in primary care, and nobody has ever paid any attention to what that means, why the patients do that, and why just the patients with frontal pathologies do that. Okay, the go, no, go task is something that there's literature that associates performance on this kind of task with orbitofrontal lesions. And so basically, this is a little complicated. When I touch my nose like this and I model it for the patient, you raise your finger. Okay? As soon as I give that command, I put my hand back in my lap so that everybody knows what's going on with the next one. And then once I've got their attention again, then I say, when I raise my finger like this, you touch your nose. And then put my hand back in my lap. So basically what happens is they tend to imitate, right? And so they're not going to respect this command because they have this impulse to imitate. And so they're going to do what you did, but they're also often psychomotorly slow. And it takes them a while to make up their mind, and sometimes they orbit around before choosing one of the two alternatives. And then they perseverate and leave their finger on their nose. If you're confident, you're going to try to go bang, 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 bang like this. Pretty soon, everybody's confused. You don't know what he just did. Is he responding to where your hand is now or where it was half a second ago? So you need to slow down for this and put a breather between each task by putting your hand in your lap till this guy's hand has been stuck in his nose for 10 seconds. Slowly nose down. And you know that you're ready to do the next task. So try to keep each individual presentation separate so that you keep And the ones in bold here, if you raise your finger, it gets to touch his nose. If you touch your nose, it gets to touch his
Now, when I touch my nose,
I want to make sure it works.
now when I touch my nose, you raise your finger like this. When I raise my finger, you touch your nose like this. Got it?
I think so.
Okay. Okay, let's try again. When I touch my
Repeat
nose,
this one once, just to make sure that they understand.
you raise your finger like this. When I raise my finger, you touch your nose like this. Understand?
Yes, ma'am.
Okay. You ready?
Yes.
Then, they've all been doing this thing with their hands. Then all of a sudden you say to him, okay, now listen carefully. I want you to do just what I say. Touch your ear. But you model different behavior. You model touching the nose and see if you're a mid-position stance. Some people seem to not be, they kind of go back and forth between the two and they end up touching their cheek. Right? You can actually watch it. Another thing that they tend to do is first they respond in a disinhibited way, but then they change their mind and go to the right one, right? But remember what I said about clocks. You should give it to them because they realize that they were making this mistake and then slowly brought it back into control. So you can give them credit for that.
Now listen.
Okay, this is the Gloria hand sequence with the palm, fist, and cut. Palm, fist, and cut. What I generally do with this is first, I walk them through each item individually just to convince myself that they're in the game and they know they can do physically what we're asking, right? If somebody had hemiparesis, I would care which arm you use. You can see the other arm, right? And so, this is the fist and then the cut, right? And then as soon as they show you they can do each of these, then you try to put all three together. Now put them together like this. Bang, 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 bang. This is actually, I think, the hardest item on the exit. It's the most sensitive to impairment. It's one of the first things to go. It's one of the more difficult items on here, which is really interesting because if you think about the exit's properties, particularly predicting forensic decision-making capacities. I mean, I didn't show you that data, but the exit probably on average explains 40 to 50% of the variance in at least 5 different forensic decision-making tests in different studies people use. Twice as much even than the variance in IDL that it explains. But why would something related to sequencing your hands, right, or motor control, be related to forensic decision-making? But empirically, that's how it works. So it's that the executive functions are metamodal and are impacting many more behaviors than just the one that's under control in the context of the exam. Without the picture. There's a little picture on your exit. This one is actually a slightly different Royall one. It's called this one. Yeah, so you should look at that on video because what you want the patient to do is to alternate between a fist and a cut at the end of this arm swing here. So you're going to model it for them and say to the patient, see what I'm doing? Whenever you're ready, start doing this. Keep doing it until I say stop. Right? And the guy immediately he starts doing stuff all over the place and it's all wrong. And so after he does that for a second or two, you can say, are you doing what I'm doing? And the guy goes, yeah, I think so. And then you say, no, again, I don't think you're doing what I'm doing. And you give him that second chance then. And if he still can't adapt and do what you're doing, then he will come.
Can you do this? Try it. It's like this.
you notice that the thumbs stick up? I think that's important. Where this comes from is part of the neurology. In the neurological exam, we test for grip strength. But neurologists tend to put their fingers out like this, with the thumbs down. In retrospect, you kind of have to wonder how that convention was adopted. Why are the thumbs forced uncomfortably down? And I think it's because otherwise they would do what happens in the exit, and they just didn't want to see that, so they got rid of it. So most people are taught to do this, especially if you're formally trained in neurology. But you know, I was just an internist, and so I didn't care. I just did what felt naturally, and stuck my fingers up and would say, you know, squeeze my fingers. But over the years, I noticed that there's a fraction of people who don't squeeze your fingers. They grab them and pull them together like this. And then when I got onto executive function, I started to realize what was happening. This is a semantic visual cue. This says go that way. This says go that way. If you present these two fingers like this, it makes them have the idea to pull them together, just like we saw in the Alzheimer's case. It's as simple as that. This has a meaning. This doesn't. You see? And so basically, you would never see this behavior if you offered the fingers during the grip testing in the conventional way. But by altering it slightly, then you can see all of these behaviors pop out. And of course, for years, I saw it. I've been doing this since I was a medical student. I just ignored it, shook it off, and went on to the next item. Your blood pressure is fine. You know? I don't know what that was about. Because I wasn't introspecting all these strange, a little bit different responses. But in retrospect, I was seeing the executive impairment for decades before I understood what it was that was interfering with my physical exam, and I treated it as a nuisance, not as an opportunity to improve my clinical diagnostic skills. Okay. Then you got the hands up, so that's the time to do Luria's slap. And then we'll see these things over there.
Squeeze my fingers. That's fine.
That's about what you can see. You don't want to make that slap real dramatic. You don't want to draw much attention to it. It's not going to be this big colossal. Yeah, it's just at the end of the grip stage, you just pull your hands out and just give this little clap and see what they do. And I wonder one of these anecdotes. One day our fellow came out of the exam room and just fell laughing onto the floor. And it turned out that inside the exam room she'd given the exit, and there was the old man with dementia, his daughter, and the daughter had a little baby in her lap. And when he went like this, the baby, the old man clapped. Okay, now this one I told you about, put your left hand on top of your head and close your eyes. And then you go quickly to the next one, right? You don't want to make too big a deal of it, but all you do is just say, that was good, and then you go to the next one, which is to say the months of the year backwards, starting with January. Okay? The transition, the only clue that you really is that the three-step command is over is your offhand comment that that's good. And then you go to the next one. So normal people pick up on that cue, open their eyes, and it's over. But executively impaired people don't pick up on the cue. They leave their hand above their head, and then they try to go into the next task. And like I said, you can go extreme with this. Sometimes with the mini-mental, they would go all the way to the end of the mini-mental. They would even try to do pentagons with their eyes closed and their hand, one hand above their head. So basically, the only suggestion that this is over is to go to the next one, and then you're going to grade how much of the next task do they keep their hand above their head. None of it, some of it, or all of it. Okay, and the next task is to say the months of the year backwards, right? But it's important that you make them do it starting with January, because you have habits to say the months of the year, but they go forwards from January or backwards from December. You don't have a habit to go backwards from January. So by making them go backwards from January, either the habit fires to go backwards from December, and then I say, no, I said to go backwards from January, and then they just get stuck, and they just go, well, it doesn't go backwards from January, right? Or the other habit fires, and they go forward from January, and just go on and on, saying forwards and forwards.
Put your left hand on top of your head and close your eyes. That's good. Can you say the months of the year?
January, February, March.
That's fine. start with January now and say them all backwards.
January, December, November, October, and September, August.
That's fine, thank you.
Okay, this one here, you count the fish in this drawing. And that's supposed to invoke a counting habit. And everybody knows, I mean, I already said that counting goes to 10. And this came from my little daughter one day when she was tiny. We were giving her the exit from the very beginning because we wanted a test that you could give validly to people as young as children that would be culturally and educationally neutral. So by giving these items to children, we were able to find items that even a little kid can attack or try to accomplish, and yet would be sensitive to their lack of executive function. So one day, my daughter is at the dining room table, and she says, "Daddy, I didn't have a count." And I say, "Okay, well, count the fish on your mom's t-shirt." And she had a SeaWorld t-shirt, right? And so she goes, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. But there were only 4 fish. Right? Because the habit doesn't stop at 4, it stops at 10. And once the habit's invoked, you need the executive function to restrain it. And so she had to go to 10 every time, and it wouldn't matter how many fish there were. So I drew up this picture, put that in a proto exit that we were drawing at the time. We went into the nursing home, and we gave this to very demented ladies in the nursing home, and they would just go to 4. And wow, that's weird. You know, giving it 4, 4, 4. It would do perfectly on this. And then I remembered an anecdote that Oliver Sacks had written about an idiot savant that he came across who could visually recognize numbers up into the hundreds. And so basically most of us can recognize small clusters of objects and know how many there are without invoking counting, right? Just from the pattern, just knowing it. And we can do this up to numbers about as big as 7. Right? After 7, you have to actually break down and start to count things because you can't see it anymore. So what was happening is I wasn't achieving the habit being released because the number of stimuli were too small. But I wanted a number that would be, you know, not quite 10, not quite 5. I thought some people might have habits to count 5. So I was going to choose a number of stimuli that was somewhere in the middle there, between 5 and 10, and force them to count. Anyway, in Oliver Sacks' anecdote, he runs across an autistic child who's, you know, sitting in front of a bunch of pixie sticks on the ground. You know what pixie sticks are, little toys that they hold. And he's going 63, 63, 63, 63. And so Oliver Sacks sits down for a second, picks up the pixie sticks, counts them, and there are exactly 63 pixie sticks. So then he grabs up the whole bundle, drops it down on the ground, and instantly the kid changes to 103, 103, 103, 103. And so he was visually recognizing much more complicated patterns than the rest of us can, right? So basically, I had to change the instruction to invoke counting. And all I did was add the fish in this picture out loud, adding the words out loud, and then having the examiner vaguely tap the fish while I do this. Invokes counting in a way that just the command, please count these fish, or how many fish are here, doesn't invoke. And suddenly counting is much more reliably invoked, and then the very same lady who just told me there's 4 will tell me there's 10. See, because now the habit is fired, and it runs to 10. Exam, right? And what you're looking for, though, is not whether they get the right name or not, but whether they reach out to grab the pen. And what people do, what I notice is that, you know, I would be in the nursing home and be asking people to name things. You don't want to name common objects like a table or the ceiling or the floor or a chair. You want to name words that are a little bit less common, a little bit more convoluted. And so I would name parts of, you know, my dress, you know, like the heel of the shoe, the sole, the tongue of the shoe, the cuff, the crease, the, you know, things like that. And then I would get up to the glasses, and I would go, you know, what are these called, right? And what I noticed was that if demented people had glasses on, then they have a life story to wear glasses, and therefore they have habits related to the use of those glasses. And those people would take my glasses out of my hand, not knowing what they are, and put them on over the glasses they're already wearing, which again, Francois Bernini has described too. Or they would take my glasses, fold them up, and put them in their pocket. And this, you take your wrists, and as though you were trying to get them to name again. And as a habit, I just noticed that as a clinician, I was waving my hand to get the patient's attention, because often they're not paying attention to you while you examine them. That's another part of their executive pyramid. When I examine you, I expect your attention to be on me because I'm the most important thing in your environment while we're doing this interview. But executives don't people to think like that. So they look at the ceiling, they look at the floor, they look at the cat walking behind you. And so they have what a lot of psychiatrists notice as poor eye contact. They're not looking at the right thing. They're looking at the strong thing. You see? And so their vision is distracted away from what they really should be looking at to accomplish the goal of knowledge. Anyway, so as an examiner, I'm subliminally, without even knowing it, drawing their attention to me again by waving my hand up and down while I say, what is this called, right? And what I notice is that they imitate, and they raise their wrist up and down while they go, oh, that's a wristwatch. But they're imitating me is what they're doing. So basically, this is just a dramatic flourish to see if they imitate that. So those are the 25 exit items. With a little practice, you can get it down into a seamless set of choreographed items. I would say that, on average, it takes a good 10 minutes to do this, but it's 10 minutes to do it otherwise to spend getting the mini-mental. The mini-mental don't do anywhere near this well at sensitively detecting people with cognitive impairment of all kinds and specifically predicting functional outcomes. Right? So basically, at 10 minutes, it's still probably a little bit too long to want to do this on every single patient every day. It would be along the lines of something you would do to clarify the diagnosis of someone who already suspected had executive impairment. I would use clocks for screening. I would give clocks to every patient I see all the time. And you'll be amazed at the high fraction of executive impairment in people that you weren't previously suspecting as having cognitive impairment. But then, if they fail box one, then it's time to think about the exit or even more formal psychiatric assessment to clarify exactly what the executive impairment is. And you may have to do more than that. The exit probably only measures one dimension of frontal function. What I mean by that is we've factor analyzed batteries of executive measures and shown that they don't all live on the same factor. And some of the commonly, test people, everybody through consensus says an executive test, like say the Wisconsin Heart Sort, is off on its own factor, not related to the other dimensions, and unable to predict functional status. See, so not every frontal function is cybernetic, but the cybernetic executive functions, I think, are most strongly related to functional outcomes, and that's why the executive does such a good job with that. And other well-respected frontal measures don't really have a literature that associates them with functional outcomes. So, anyone have other questions about the exit? Yes, sir.
On the page drawing, what was the other?
Oh, other response, yeah.
So they named something other than a fish?
Yeah, they might say, oh, that was like turtle name, right? And you just can't create that. But it's not right.
Because let's say they don't get the fourth fish.
Right.
They say, there's 5, and they also include some other fish.
Yeah.
Then
Yeah, if they say a number, then it's pretty easy to score. The other is for the fact that sometimes they say things you just can't quantify in terms of numbers. Yes, sir.
Is there a practice effect in the
Oh, that's a really good question. Is there a practice effect in the exit? You'd be surprised. I don't think there is. In fact, we've published longitudinal slopes of change on 20 different cognitive measures in our retirement community. And so slopes have no variance, right? So when a measure improves with no variance in the improvement, then we attribute that to a learning effect. And the Wisconsin Card Survey is one of those measures. You can only give a